with Dr. Diane Darby Beach, and we are so excited to have her today on our vlog. And Diane, tell us why you're so excited about gerontology today.
Well, this is the tsunami of healthcare.
I know.
The good news is we're all living longer, but now we've got this risk of getting dementia and specifically Alzheimer's disease. So I really am excited about what you're doing here and how we're focusing on these folks and helping them have a good quality of life toward the end of their life.
Oh, thank you. And I really want to thank her and let everyone know that Diane has really helped our training and our empathy, and especially our sensitivity training for our caregivers and nurses and administrators. Everyone here has taken all of our classes on communication with older adults with dementia and the various approaches that she suggests. That's super helpful and really have helped our care.
Thank you very much.
Thank you.
So tell us a little bit more about how the caregivers have translated what they've learned in my classes to their actual care and given them some tools.
Well, honestly, you are so great on empathy and really relating that to the caregiver, because training is training and learning is different. Learning and motivation, and it's just a deeper level of understanding that our caregivers have received from you versus just training. And I think there's just a big difference. So when you come here, I think your hands-on training is just superb. But not just in the way you present it, it's the way they understand it. So I think, again, it's probably the sensitivity training. You're using live examples, you're using residents, and they really take that to heart and then internalize it and store it, retrieve it, and it works, Yeah.
Well, we have this movement now, especially in California, to have less use of the antipsychotic medications.
Yes.
How has my training helped reduce the use of those kinds of medications?
Well, that is so critical. You've been really helpful in making sure there's an antecedent, asking the caregiver to think what happened before. And your approaches to that are critical. What can we do? Well, how can we figure out what caused this? And then telling their supervisor, this happened, that happened before the incident. That way the supervisor, the nurse, or the med tech can really problem solve. What else can we do? So I see them kind of internalizing, reporting faster, and then calming down themselves, because you've given these great techniques on stepping back and just waiting before they really react. And so those kind of tips have really been helpful. The reporting and then the actual de-escalation of themselves, of the caregiver themselves, has really helped.
Well, thank you. And I think that's very true. I always tell them, really be aware of your own energy and what you're bringing to the situation, because the resident is so sensitive and can pick up on that really fast.
Yeah, and your tip. So we can't change their behavior or their delusion, but we can change our response to it, or our approach, and all those approach ideas you've given us, stepping back, trying music, trying redirection to another room, turning the lights on. All your wonderful ideas really have helped. Even weighted blankets. I mean, you come up with the greatest ideas. I can't believe it. But they are very helpful. And they do take the place of antipsychotics many times. Many times they don't, but at least we're trying that first.
Exactly. And then the use of antipsychotics, we can start at the very minimal level and then titrate if we need to.
And Diane, antipsychotics are so complex. And of course, we don't want anyone punching a hole through the window or hurting someone or striking out. However, physicians seem to just jump there. And so we have to be careful as a facility when we call them and say, this is the behavior, to give the whole story. And you've mentioned that many times, is when you're reporting to the physician, the LVN or whoever it is, just to give the whole story so they get a clear picture.
Right, and it's the geriatrician or geriatric psychiatrist that ultimately makes that decision.
Right, and even a great internist who has a lot of experience. I mean, they might know the resident, but they are the decision maker, and it's their license, so they get to choose. However, we just have to be careful we're giving the whole story about that resident, what's going on, what we've tried, and communication, again, is so critical with antipsychotics. Yeah,
absolutely.
It's a tough issue.
And then titrate if we need to. How about person-centered care? I really try to help the caregivers really understand each resident's kind of psychosocial history. What were their routines? What did they like? What did they dislike? What did they do for a living?
Right.
You know, how has that helped?
Well, you've given us so many tools, but the one tool I love is the bio ahead of time, and just really doing a better job on the pre-admission appraisal of articulating not just food preferences, which is always there. I mean, that's important. That is important. But what they did for a living, you know, like you said, occupational, and just the way in the last 5 years, because there is a new normal. So not going too far back, because that might not be relevant. But what is their new normal? What was their routine at home or in their last place? Because transition's difficult.
Yes.
But if we know more, we do a better job with transition. So that point in itself is critical from you. So thank you for that.
Oh, of course. Can you think of any specific examples where, you know, the history kind of played into the care plan?
For sure. I
residents?
can think of a man who was a toy maker, and he was with Mattel. And so we went back and brought all the toys, put them all in his memory box, and then around the room, and immediately when he walked in, but he remembered that, so that was critical. And he just said, oh my gosh, here's my room. So it really, really helped. And let me think of other examples. Gosh, there's so many. I would say with nurses, you know, when you have an admission of a nurse, that you have to really put on that nurse hat because they don't lose that nursing approach, you know. So for sure, occupation is critical to note. And making sure, I think, disseminating the information of the bio is critical. And I think we didn't do a great job of that in the beginning. And ways we've done it through email, posting, our 3:00 daily meeting with the change of shift. We just bring the bio out and reiterate it. So I think it's great to do, but it's got to be communicated properly to every level.
Yes.
So it can't just stay at the top. Everyone needs to know about, you know, this new older adult and all their wonderful history and personality and maybe even obsessions, whatever it is.
Yeah, and they all have them.
Yeah.
So lastly, I would like you to just comment on how have I helped the families, because the residents are very important, staff is very important, but our families need support. And what have I done?
Well,
to
I
help
think
them?
your biggest talent is your compassion, and you are really compassionate with families. And Diane, there's never been a family that has spoken with you that doesn't feel relief at the end. So, and you don't speak in ageist ways. You don't look over them. You don't not address the resident. I mean, you're one of the few, you know, I know you're a gerontologist, so that helps, but not every gerontologist really has that respect. So when you're listening to them, you're reflecting, making suggestions, but you're not all about try this, try that, and I even get that way, and I have to really step back and think about, you know, where are they really hurting? And you're able to kind of get into that hurt spot and really make them feel comfortable and validated. So the validation, I think you should just continue doing. You're so good at it. But I can learn a lot from you, and I really appreciate it.
Well,
so
ditto.
I think that's really your biggest talent, is you validate them. At the end, they just feel so much relief. So
great. Well, thank
lucky
you.
to have you in our industry.
Well, I love being here and being with you, so thank you for having me.
Oh, bye-bye.